Hi, folks. This is John Adamson, the Rehab and Documentation Guru, partly responding to a comment that I got on one of my videos and also related to a question that I've heard repeated over and over again, or statements I've heard repeated over and over again from the thousands of therapists I've gotten a chance to meet across the United States and teaching my courses. But first, I just want to say this. Please like and subscribe. This helps the YouTube algorithm. It helps drive my videos up in viewership, which allows me hopefully to eventually make this more of a not full-time job. I doubt I'm going to be a full-time YouTuber, but helps in that area. So anyway, let me give you a little scenario to get into the content. So suppose you're in a surgery, you're being operated on, and you're having local anesthesia. So you're awake for whatever reason, you've got to be awake for this surgery. And you hear the doctor explaining things to you and talking to his or her colleagues. And then suddenly, at 38 minutes into the procedure, a bureaucrat from the hospital pops into the operating room and says, "Doctor, what are you doing?" And the doctor says, "Well, I'm doing my procedure. I got to finish this up, and then I got to close this patient's surgical wound up, and then I'll be done." And this bureaucrat says, "I gave you 38 minutes to do this procedure, and that's all you get. That's all you're scheduled for." Can you imagine that happening? I mean, especially if you are the patient listening to this and going, "Wait a minute, I've got my guts hanging out, or I've got exposed tissue underneath my skin. There's no way that you should be wrapping this up. It's medically necessary to keep on going." And the reason I bring this up is because I have heard so many times over and over and over and over again from therapists saying, "Well, I'm treating my Part B patients to 38 minutes or 53 minutes or whatever it might be, and that's what I'm scheduled for, and that's what they expect me to stick with." Just as we would not tell a doctor that this is all you get for your surgery and that's all you get, we should not be having anybody tell a therapist this is what you get for treatment and nothing else. Now, let's face it, a doctor is operating under a CPT code that gets paid for that one unit of care, regardless of how long it takes. But the longer that doctor's in surgery, the less money per minute they're actually making. So it would make sense from a productivity standard to say to a doctor, this is how long your surgery should take, and that's all you're getting. If we're trying to control costs, because the more minutes that they're in the operating ward, the more electricity that's used, and there are people on salary that are helping him or her with that surgery. So it would make sense to control for minutes, but they don't. Why? Because patients aren't cookie cutter in their approach to the care they need. Neither should you be. And this is something that needs to be stopped. You need to, as a clinician, be telling your DOR or your regional or whoever it is, this is how many minutes I need, and this is how many minutes I need scheduled for this patient. Because that person was not there doing the evaluation of the patient. That person was not there during that individual care, seeing the patient's reaction to your care, knowing the patient's goals the way you do. We're lucky if that person that generated the schedule and gave you those 38 minutes or 53 minutes or whatever it was even knows the patient by name, by their face when they see them on the unit or in the home setting or whatever it might be. You need to be the one picking the minutes for the individualized care. That's so essential. And I know some people will say, "Well, if I go over, I get written up. If I go over, I get a talking to, blah, blah, blah." But we're part of the problem if we capitulate. And so I would encourage you to do this. If you're in a situation where you've been told clearly you will treat to these minutes and that's all you get, I would mutiny. That's a strong word, but I would talk to your coworkers and say, "Hey, I've got this patient and I've been scheduled for this many minutes, but I need really this many minutes." And I bet your other coworkers will say, "Yeah, well, I've got this patient that needs this many minutes and I've only been scheduled this many." And mutiny together. Just say, nicely to your director of rehab, "We have these patients. They need this amount of care, and this is what we're going to provide." And if you all do that, are you all going to be written up? I mean, if there are companies that will do that, I'd be partly, one, surprised, and two, I'd be surprised if they're anything but a small minority of the companies out there. And if you routinely make it clear to your operators that you will be the determining factor in the intensity of care, the minutes of care per day, based on actual clinical need, and of course that's important, showing clinical need for those minutes. If you show that you're going to make those decisions and you push back gently but firmly, and you do what the patient actually needs, you're going to help solve one of the biggest problems that we're facing in healthcare right now. And let me point out one other thing. So I used to do auditing, and I used to do appeals management. And one of the things that's very dangerous for an organization is if they routinely treat patients to the so-called 8-minute rule. So you have billed 38 minutes, which is 3 units of care for Part B. The reviewer can easily look at your note and see, did you really need 38, or could you have gotten by with 37 minutes? In which case you only get 2 units of care paid for. So billing to this so-called 8-minute rule is a bunch of baloney, and it should not be done. There are times when you're going to bill a patient right up to, let's say, 1 minute before the next unit, but maybe that's what was clinically appropriate for that day. Sometimes you may bill right to that so-called 8-minute rule, which is no rule actually, guys. And that would be clinically appropriate. But the bottom line is this: treat every individual patient individually on an individual day, and stick up for what you know is clinically necessary, and do not capitulate to people that are saying this is all you get for your scheduled minutes for this patient today. That is baloney. That goes against everything that Medicare has been saying with the payer changes that are going on. It has legal and ethical ramifications, and it undermines your authority as the clinician in the case. Anyway, this is John Adamson, the Rehab and Documentation Guru, on a tear with videos today, but just having all sorts of questions, comments, and concerns brought up, and just wanted to address them in a timely way. Take care, and God bless.